arthroscopy, especially the posterior horn.
These are the
Thank you.
arthroscopic blind spots which you should know.
Yeah. Thank you, sir.
Sir, can I speak for 5 minutes on this issue?
Sure.
Okay. Thank you very much. We have discussed a lot on the knee case, but in my opinion, the knee case only is not ACL and BCL and two collaterals and menisci. Here the knee joint does not stop. You have a lot of patient short cases where there is a synovial involvement. There is no joint involvement. So in those situations, especially the students not pertaining to any test, in those situations, the student must know how to test the temperature, how to test the tenderness, where to feel the synovium, how to do the patellar tap, how to feel the effusion, what is to be done with the effusion, and how to do the tenderness. Because a very important and essential part of the knee is salvionum and the capsule also. Maybe associated with ACL, may not be, because in knee case there may be tuberculosis, synovial effusion, there can be pyogeny, there can be so many things. So not by knowing 4, 5, 6 tests means the knee. Knee means when you present a short case of the knee, there can be, how many people can tell here where to palpate the synovial membrane in the knee joint?
Medial. So pyramid.
Why medial? Because medial has the most thick muscle. Why medial is so thick muscle?
Vastus major.
Why we palpate on medial side? Why not lateral anterior?
Atrophy first start there.
No, one. Yes. So we palpate on the medial condyle femur, although the muscle is very thick, but it is the first muscle which gets wasted, and we can palpate the synovial membrane. You can roll in your finger. That is one point which I want to add. I am not saying any test and anything else. Secondly, when you do tenderness, you should do with your both like this, not like this. We have two hands and any inflamed area. 2. Number 3, you must palpate the joint line which has been discussed. If it is anteriorly, it is osteoarthritis. If it is posteriorly, likely it is to be a meniscus. Then synovial effusion. As Dr. Gautam has mentioned, a minimal fluid in the joint. In children, by standing, you can see the fullness of the eyes of the joint. But in adult, if there is a minimum fluid, then you have to just press and collect it in the joint and see. The patellar tap will be negative. When patellar tap will be negative? Because these are the examination questions. When the patellar tap is negative, although there is a synovial effusion, but tap is negative. So when there is a tense hemarthrosis or tense fluid, it will be negative. And another?
If there's a flexion deformity,
Anything else? If there is a tense, if there is a flexion deformity? So, Joseph. Huh? Not abscess. There is this synovial effusion when the tap is negative. One is it is negative when it is too tense. The another is negative when the fluid is minimal. Then also patellar tap will be negative, because when you do the tap and if the patient is having a cyst on the posterior side, the whole fluid goes on the back side if it is connected with the joint line. You understand? So the tap will be negative on those sides. Thirdly, the student most important. He had made a suicidal attempt for the examination. After the examination, he said, I will do arthroscopy. The examiners asked, what you will do? I will do arthroscopy. Means he knows the patient. He knows the clinical diagnosis. he has seen the MRI. This is the inference which is taken by the examiner. Otherwise, he should have asked for the X-ray, for the MRI. Although he is sure, but he should ask, not immediately jump. What I will do, totally without confirmation. And many a time, I have been examiner in DNB long time, many a time you jump, and then there is no scope. That you are jumping, you are telling the right diagnosis, you are telling the right treatment, but you are not confirming the diagnosis either by the X-rays or the blood or thirdly, when there is a synovial effusion, one is you can see by the tap. Secondly, you can see by the palpation that fluctuation is positive. What is the confirmatory number? Ultrasound. Ultrasound will not much tell whether it is a fluid, whether it is a blood, whether it is a pus. Aspiration. So when you aspirate, what you do with that aspiration? You have aspirated 10 cc, 20 cc, 30 cc. What three things you should do with that aspiration?
Routine microscopy.
So you send it for culture. All culture should be biopsy, and you do the biochemical test must, because you have already done a invasive method. You have put in a needle inside that joint. So you must take maximum inference, not that just to show the examiner or to show the students that you have aspirated, maybe intrabated, maybe passed, and then all these tests which has been discussed in great detail, I see. So the tap, the tenderness I already said, anterior and posterior, locking. What is locking?
Enable to extend.
Positive. What? Or flexion. No, why not? Why locking is not flexion? You can lock either way. When we say that the knee is locked, why it is always in extension?
Always locking is there extension.
There is no locking in flexion. Any answer? Hello? Yes? Joint spaces? Yes. Because the moment we start flexing, the space started increasing. It is in extension, full extension, the joint space is narrowest. That is why the locking, when we call it locking, patient is unable to fully extend the knee joint. That is the reason that we call locking extension. Then, no comment he has made on the wasting of the muscles. We must always make a comment about what is about condition of the wasting of the muscles around the knee joint, especially the high ones. And the infusion, I have said, the temperature we must always do. So these are few things which I have added, not to ACL or PCL. When you may get a case of synovial fusion, not necessarily always get a case of ACL and PCL.
Yeah, I think I'll slightly tend to briefly disagree with you on one account, that once we are dealing with a particular clinical situation, we have come to know, particularly in a short case, the examination of the knee can take 1 hour lecture like this. Everything, you should describe everything, the time is short. So you have to finally kind of concentrate and focus in that direction more rather than describing anything. If there is no synovial effusion, if you say particular time is negative, I think that will take time. As a theory lecture, it is alright, all those things you are telling all students should know. That if there is a fusion, aspiration should be done, but not otherwise that in every case you must mention every finding of the knee joint.
Prepared. Somebody you should talk.
In case a different case comes, in case a different case comes, we focus in that direction.
I am just telling that not pertaining to this case. When we have, because we don't have many knee cases, we do not have many knee cases. I just wanted to express that in knee cases, you should have look on these also. If it is this particular case, no tap, nothing is required. But sometimes there is a effusion, sometimes in knee cases, different.
Thank you very much for the